Good morning to you all again. Today I am going to discuss with you ethics in surgery. Ethics in surgery will be covering under the three heads. Number one is introduction, autonomy, informed consent, practical applicability, life and death, confidentiality, research, and clinical excellence in surgery. Ethics is very important aspect of the most exalted life that is human beings. Ethics does not apply to one particular group of people, but it applies to the entire humanity, to all human beings, whether he is illiterate, whether he is educated. At times, you find illiterate people more fulfilling the criteria of being good human beings, and highly educated people, very rich people, have nothing to do with the norms and the ethics. It is natural, I don't know whether it's acquired or it is inherited. But both things matter in life. Inheritance also matters, and whatever, the cultivated thing, that what we learn through reading the books, watching people, living with our parents, relations. At times it also happens in a family, the view of the son and the daughter differs from the parents. And at times it also happens the brothers, they are the first degree relations, brothers and sisters. And ultimately at the end of life we have seen that throughout the life, in childhood they have been playing together. When they grow up, then each one of them is, yeah, please come on. Each one of them is at his own. They have chosen their own professions and they are working independently. But when the parents are gone, when it comes to the question of inheritance of the property, then the real, which we never believe that the family, brothers and sisters which have stayed together, ultimately will behave in a different manner. So I am trying to correlate with my talk today with the ethics. Ethics means a cultured behavior, truthful, virtuous conduct. And in a particular profession like surgery, we are very responsible because we are dealing with the lives of the other people also. You get my point? So, for a doctor, there are few things, even if any doctor becomes irresistible in his speech and behavior, but before the patients, he has to be very gentle and polite. The patient should have trust in the doctor and the surgeon. It should not have. There are many people who are excellent in their professional behavior, in their occupation, in their skills. They are very much advanced. But in their attitude, they are different. People are scared to talk to them. So what is the point, in a good doctor, an excellent doctor, a successful doctor, if he doesn't know how to talk to the patients and patients get frightened? So he'll prefer that he will go to a doctor who is sympathetic, who is sporting, and he has got a kind attitude towards others, kindness and compassion. But if there is a doctor who is very good, but and keeps on shouting at the patients and the behavior is atrocious, doesn't pay much attention, but he's skillful. So therefore you people will say, patient will feel, I don't want to go to the doctor because I feel very insecure. So our idea is not to create some kind of a fear, some kind of a fear or terror in the mind of the patients. We have to give them confidence. So under these words, let me tell you, you are all going to become doctors, and many of you, please don't make noise, and many of you will become surgeons also. So therefore, you have got a special responsibility. You imagine you will be controlling the lives of the people who are sitting before you. You are operating upon him. Okay, he has given his life, he has put his life at stake and handed over to you. He is knocked down under anesthesia and then you are the master. So therefore, he does not know about your skills. It is the responsibility of the patient also when he approaches the hospital for treatment or he is to undergo surgery. He must see what is the reputation of the doctor, what are his skills, what are his results, what is his surgical skill. So that kind of information people generally seek these days. So what I mean to say is that you are given a very big responsibility by providence to tackle the lives of others, decide the fate of others. Now, you put a knife on the patient, what are you doing? The patient is being inflicted with a wound, injury, and there is another person, a criminal, who harms the other person. Both are doing the same thing. But what is the difference between a criminal who injures other person and a surgeon who inflicts injury to the patient? What is the difference? It is the intention. The intention of a criminal is to harm somebody. But the intention of a surgeon and a doctor is to help, to promote health, and to save life and patient from the disability, save the patient from disability. So that is the difference. Okay. Even patient doesn't know what will be the outcome of surgery, whether it will be successful or it may not be successful, because surgeon he is a person who is discharging his responsibility, but the outcome depends upon the severity of the condition what he is operating. You get my point? It may be a very difficult surgery. It may be a surgery the patient has reported to you in a critical state where the chances of survival are quite less. You get my point? So therefore, he has to take these things into consideration, and that is why we have a system where before we put our knife on the patient, we have to prepare it for surgery, and therefore, under this thing, one of the most important thing when you tackle the patient, a surgical patient who is awaiting surgery, is autonomy. Autonomy. What do you mean by autonomy? Autonomy means patient is fully free and to give his yes or no for treatment. He is fully responsible to say, a doctor tells him, he sees in OPD or in the wards, he goes for the rounds and tells the patient that you have so and so ailment and therefore we are going to treat you. Possibly you may require surgery, you will require surgery. He is fully free to say yes or no. It is his autonomous behavior, it is his freedom to say that I will not undergo surgery or I will go under surgery. Or he has agreed to undergo surgery but then he refuses to undergo surgery. We are nobody to force surgery upon him. Is that right? So autonomy means a person has full choice to know about his illness, his ailment, what's going to happen in, what will be the progress, after how long I'll be on, all right, and will it affect my occupation, my sports, my social life, and my other things in life day to day with the earning and other activities are concerned. So you cannot force a patient and shout at him. You have to agree to what he says. This is called autonomy of a patient. All right. Then autonomy means yes. It automatically translates into the next step. He has agreed. Yes, sir. Do whatever you want to do. Then comes to the second point of informed consent. Informed consent. Informed consent means that you have to tell the patient, this is your disease and the treatment is surgery. So you have to apprise him that this is your condition and if you don't get operated, this can happen to you. So in informed consent, you have to firstly inform the patient what are the plus points of surgery and what are the negative points of surgery. How the patient will be benefited, how patient can be harmed also. Suppose you are going to operate on him. Many of you probably may become surgeons and eye specialists or ENT surgeon, whatever it is. Now, here the attitude of surgeon has to be very, very strong. You cannot hide anything from the patient. Even if it's a great Olympian or a sportsman, and you are going to operate on his muscles or neck or somewhere else, which will affect his capability, might affect. Now he has come to you with a problem which can be cured by surgery. So we should not give the patients false assurances. False assurance means that some of us will be in doing private practice, some will be in government service. The attitude and behavior of doctors and surgeons in private practice, PP, and those who are working in government hospitals, seeing 200 and 300 patients a day, and he has a voluminous amount of workload upon him. One is sustaining himself through the pay which is given by the government, right? The other one is running a clinics and hospital, as you know, there are nursing homes and so many things in our country. So the behavior, because a person it is a market, you can say, commercialization of the health services. So one has to be extraordinarily polite and inviting to the people by his approach, skills and logistics and everything. So you cannot hide anything about them and should not. Even a person is in a government service, his behavior and attitude should also be very, very kind to the patient. So therefore, suppose a person is to undergo eye surgery, cataract surgery. If I start saying that in my hand, look, when I'll operate, these are the problems, you can have hemorrhage and you may become blind also. It's a very radical statement. When you tell the things, what can happen to the patient can have anything. You have to tell him you can die under the anesthesia or surgery. It is very, very difficult for a surgeon. He will not be a successful, he's causing harm to his own reputation, right? So what I mean to say is that you have to tell him that this can happen. You have been operated in one eye, and this surgery you can become blind in the other eye also. So patient will be frightened. He'll say, no, I don't want to undergo surgery. But you have to tell him. You have to tell him what all can happen, all the side effects, that if you operate on your neck, the accessory nerve will get cut, and so that you will not be able to participate in sports and games. And these things are recorded in the books, what I am saying. You get my point? But law demands, you see, the surgery, law demands, a patient can take us to the court if we do not inform about his ailment, about the negative aspects and the complications of surgery. You have to tell him. But in our country, things go, we don't, talk to patients so much. So we have to have a good communication skill with the patient. बात कैसे कर रहे हैं patients से? You have to impress the person. Look, we'll try our best to do your surgery. This is elective surgery, not an emergency surgery, or it's an emergency surgery. So therefore, you have to tell him what are the complications. Number two, you have to tell the patients about the progress and the outcome. What can happen to you? You will recover nicely and do quite well. Okay. So, if God forbid you have taken the consent, and consent then you have impressed him, you have talked to him, where are you going to talk to the patient? When I am going to operate on a person, you are going to operate on a person, so therefore take the patient into confidence, and only that person should take the informed consent of the patient who is himself going to operate. There are big surgeons, they are quite busy, so they send the nurse and the junior doctor, take consent on the form, and you go to the patient and somebody writes something on the skill, the name and everything, particulars, and you take consent for surgery without informing the patient, without telling the details. He doesn't know what kind of surgery I have to undergo. So nobody talks to him because there's a lot of rush in the hospitals. So therefore, you have to spare some time. It is no good thing that a person, a junior surgeon who has never operated in his life, so you'll be, the person who's going to operate is immediately concerned. So therefore, a person who is going to operate on a person, he should take the consent. And where he should take the consent? Preferably in a quiet room where nobody is there to disturb. He may not know your language. He may not understand your language when you are briefing the patient about his ailment. So therefore, you should have a services of a translator also who can understand the language which the patient understands. So that translator is required. And you see that informed consent, you have to talk to the patient in a simple language, the language which he understands. We talk to him, said we'll do the tension-free mesh hernioplasty, he will not understand that. So you have to talk to him in simple words, right? Then you have to tell him what all things can happen and what things can improve your condition and what are the alternatives to surgery, if any. Don't hide anything. You have to tell him whenever a complicated case comes and he seeks your opinion, you must say, look, so and so is far, far better than myself, you go to him. His results are much better than my results. That kind of a, moral strength a person should have to tell the patient, right? That I want to take a cross opinion from somebody, some other consultant, right? And also, in informed consent, what you do is you have to make notes also yourself, and everything has to be recorded. You get my point? And if you operate upon a person, you are doing your best, God forbid, if he lands up in some problem and you have not taken the consent, there are conditions when you have to operate when consent is not there. I will discuss it. So, if something goes wrong and you have not told the patient that this can happen to you, then the problems will arise. And what are those problems? What are those problems? They are criminal negligence. Criminal negligence, unintentional. But you have not informed. Patient will say, very nascar, he has cut my nerve and I have become, I got a neurological deficit, right? And he goes to the court and you have not taken the consent, so it amounts to negligence and the law will take its own course. Therefore, another thing which I want to tell you is that when you're operating, a male surgeon, when you're operating, when you're talking, when you're examining a female patient, the female attendant should be there. But doctors have been punished in our country who have examined the female patients without a female attendant. They have been imprisoned. They have been imprisoned. The judge has not listened to them and they have gone through, this thing. So this is very important that please register it that when you examine a woman, female attendant should be there. Another thing, if you touch the patient, male or female or anybody, without consent, now you are examining a patient, you are operating on a person, but in a simple language, if a person, individual touches anybody, this amounts to, if I do something like this, it's kind of a gesture, you and then touch him or touch her and things like that, this means it is a crime, an offense. Indian law does not permit it. This is called battery. This is called battery. That means touching somebody appropriately or inappropriately without consent amounts to battery. So these two things are very important. One is negligence, where you operated on a person without consent, it amounts to murder, no intention. You get my point? So these things are very important. Now, as far as consent is concerned, who is able to give consent as far as patient is concerned? This is called a person is competent or incompetent. Who is competent? Who is competent who can give consent for surgery? Individual himself. But who is competent? How you find out that this person is competent to give consent for his surgery? The person should be the individual himself, and he should be conscious, oriented, coherent. He should understand. He understands what doctor has told me. I want surgery for hernia, and he has explained to me we'll put a mesh. This is a small incision. It is a what you call laparoscopic approach, or it is an open surgery. We'll put a mesh. So you have made him understand that this procedure we are following. Okay, and he understands the implications, negative points, positive points, recovery time, everything. So a person is competent to give consent if he understands about his ailment fully, and you have to check back, you have to see that. And second is that he remembers that. And thirdly, he'll have some queries with you, he'll have contact with you, have some discussion with you. It takes good time for a person to convince about, to undergo surgery or not to undergo surgery, things like that, pros and cons. And then this is his ability to talk. The person should remember, he should understand, and should be fully able to discuss his problems. But we come across certain situations in our life. There are many categories of people who cannot give the consent, and we have to operate. And if you operate without consent, law is there to check you up, really. So you have to balance that kind of a thing. But one thing is there, your job and responsibility is to save the life and prevent disability somehow. Okay? You have to do good. The intentions are to save a person who's dying, but he cannot give consent. A person who's unconscious, sustained injury, will you wait for the consent? You have to resuscitate him. Immediate resuscitation and immediate surgery may be required. He might be thrown into operation theatre, and you see him. I have operated so many things in my life, including ruptured ectopic gestation also twice. There was no time. Patient was in shock, so we straight away took this thing in. Patients with trauma, both limbs amputated because of vehicle accident. So therefore, in some situations where somebody's life is involved, you cannot operate on a person. You cannot mind even to an emergency. But in normal situations, the patient, there are sometimes persons who will not give consent for surgery. So you cannot force them to give consent for surgery, right? This is his autonomy. This is his independent decision. Then there are people who are intoxicated. A person who is below 18 years age. Children. A small child has been brought to you by somebody, some caretakers, caregivers. So child will not be able to decide about his, he does not remember, does not understand the implications of surgery. So in those situations where somebody's life is involved, yes, you can operate without consent also. Then comes these patients who are psychiatric patients. All psychiatric patients are not incompetent. He may be person may be having some kind of illness, or he may be not able to give his consent. So those people who have brought him to the hospital, they can give the consent for him, who are immediately caregiver. But otherwise, a person who having this ailment, if it's not an emergency, he can wait till the time he is in a fit state to give consent for himself. Is that right? So in some situations where a patient person is not able to give his consent, you can get the consent from the hospital authorities by explaining, sir, this person is having so and so problem, and if you don't operate on him, don't resuscitate him, he might lose his life. So in those exceptional circumstances, things are a little different. Then comes your practical applicability. Practical applicability. It is written in the books. In some of the countries, the law is very clear that you cannot touch a patient without his or her consent. But when you are taking around, when you are seeing 100 patients on OPD, will you be able to take consent of everybody, informed consent? Is it possible? Is it practical? It's not practical. Then what do you do in such situations? Because in our country, such kind of charges and things like that, they are not very common. It's quite uncommon. Patients generally keep quiet. Some of us sometimes may inadvertently touch the patient. So when you go for a round every day, what do? You take the consent? No, you can't take it. It's not practically possible. So a simple word of sympathy, you have to talk to the patient. Look, I have come for the round. If a new patient, you have to explain to him so and so. Otherwise, every day you are coming to every patient, you say, Okay, you put the hand on the pulse, it's perfectly all right. There is a, what you call that, a potential extent, severity of, your approach to the patient. If you touch the, you have asked the patient certain question, you see the pulse, perfectly all right. But if you want to examine certain parts of the body, you have to ask the patient, look, I have to examine this particular part. Do you agree with that? That also in complete confidentiality and privacy. You get my mind? So during the rounds, they tell each and every patient that I want to examine you. They're perfectly all right. Patient says yes, sympathetically understands your approach and the mind. There's nothing wrong, right? So these are the practical problems you will be facing. And other problems which might face is particularly with the children. When nobody is there with the child, in this situation also, you see that a child is, if he understands, if you are able to explain to him the problem, the surgery, the child is fully competent to give the consent. That is also there. But otherwise, you have to obtain the consent, there is no doubt about it. So, life and death. You will be seeing a lot of patients during your practice, and I'll talk about behavioral aspect also in these situations. Now, a person who's running a nursing home and a person who's working in a government hospital, there is a difference of approach. A person, you see, many of us have taken loans worth hundreds and crores of rupees to make a hospital. Is that right? Do you understand what I'm saying? Do you expect him to do the free service? Can he do it? He'll starve himself to death. People are there who have taken loans and loans and loans from many hospitals, made beautiful nursing homes and everything. And then, when an emergency comes, they have to treat emergency patients, isn't it? When you become a doctor, which doctor will say there's an emergency, you go back? You will not see his pocket. And after you have treated the person, he goes to ICU, he is on a ventilatory support, all kind of specialists see him, all kind of logistics and medicines are used over him, and the bill comes, he says, I don't have any money, what do you do? Will you take off his, take him out of the ventilator? So you can't do that. You're in a catch-22 situation at that time. So, and then, even if a person is able to pay money and he is on a ventilatory support for 30 days, and how much bill has come? Bill has come to say, oh, what are the ICU charges? It ranges up to even 10,000, 20,000, 4,000, like that. And what happens is that he is not able to pay money. Now, when to this? He is on a ventilatory support. So what do we do? What do you do at that situation? So if he takes it, the intratracheal tube out, the patient will die. Okay, patient will die in case he has got that kind of a problem. Now, who decides whether this patient, we should withdraw his life support system, because his life expectancy is nil after withdrawal of the resuscitative methods? That suppose a person who is knocked out with this thing, what you call relaxants and things like that, or he is comatose patient. How do you decide? Now, what do you do? Because the patient, you continue to treat the patient's attendants are not able to pay the bill. So this comes under this life and death, how you tackle. So one has to be honest in the conduct. You cannot put a person on a ventilatory support endlessly, knowing fully well the outcome will be death with or without ventilatory support. Patient attendants must be clearly told, here the profit does not matter. The profit should not come in way of your judgment. the independent judgment. You have to be very frank. Your motive should not be that I'll keep the patient under ventilator support in emergency or ICU or HDU just because that element of greed is there in the mind that this will fetch me money. So you have to come out of that opinion. You must be having that kind of a humanitarian aspect of life in which the profit does not matter. What matters most is your prestige and the honor. Okay? So, a person, then you have to decide. You have to take your senior into confidence, and a person who is on ventilator support explain to the patient's attendants that if we take out this thing, the ventilator support, he is brain dead. If a person is brain dead, pupils are dilated and it's fixed, but he is on a ventilator support, his pulse is there, so you are falsely, you can say his pulse is all right, his blood pressure is also normal. That in any case would be, even in a brain dead person. Please tell them clearly, no, you tell the attendants, please sign here that we should slowly and gradually remove the sports system. Okay, that is one. Second point is a palliation. Palliation, a person is unconscious or patient is under ventilator support, but you find that patient has been treated. You have got patient had carcinoma of the breast and there are mets everywhere. Patient is having excruciating pain, right? Now, person has got excruciating pain in the hospital. What do? You have given all sort of treatment to him. You have given all sort of treatment. The patient has got chemotherapy. Patient has got adjuvant chemotherapy. Adjuvant means before surgery. You understand that? Adjuvant chemotherapy means that you give chemotherapy agents for cancer so that stage comes down. It's called adjuvant chemotherapy and radiotherapy. He has been subjected to surgery. The patient lived fairly, say 2 years, 3 years, 5 years, whatever it is, but lands up in the hospital, severe bony pain. What do? Will you leave the patient like that? You will give the patient narcotic analgesics. That is, the patients, you have to control the pain. This is called make his life comfortable, because in any case the patient is dying, has to die within terminal state. So law permits you, the medicine permits you for palliation, give painkillers. But if you give painkillers, the attendants will docs up, this patient will become habituated to narcotics like morphine or methadone or something like that. Narcotic analgesics, patient will become addicted. Patient is already in terminal state. What kind of addiction and things like that you expect is going to survive? So the patient must be given palliation. And there is a much little difference. The amount of narcotics required to make the patient painless and death, there is this called double effect. It is written in the books, double effect. If you give narcotic analgesics, the amount and doses which will relieve him of the pain and the death, because the respiratory complications are there in respiratory depression is always there with narcotic analgesic. So therefore you have to decide it. But however, you cannot deny patient the palliation. Okay? Then comes in this aspect only, that is intentional killing. There are all kind of people in this world. People want that somebody is inheriting a lot of money and things like that to get rid of the old man. So that kind of willing should not come, and doctor has no business to get himself involved in property matters and familial matters. He talks up, give him some dose. We are fed up. We are here in the hospital for the last 9 months, and whole family is disturbed and things like that. He's not going to recover. No, you give him some dose so that you are also at rest and we are also at rest. They are very dear to us. My grandfather is very dear to us, but we have suffered a lot, and we kindly deliver us from this problem. Give him something so that he goes to heaven or anywhere peacefully. This is called intentional killing, and voluntary euthanasia. Euthanasia, intentional killing and active euthanasia. Euthanasia, you understand? Euthanasia, euthanasia, euthanasia means giving some kind of a medicine or anesthetic agent so that person dies. This is called intentional killing. Never do it. Indian law does not permit it at all. Right? Another thing, whenever you say to a patient that we are going to do this operation upon you, which will require general anesthesia, all right? And during surgery, the patient has given consent for, say, smaller, say I undergo tubectomy or vasectomy or things like that. These are very minor operations, but no operation is minor as far as surgical practice is concerned. And you have told the patient you are going to remove a cyst from the peritoneal cavity. Any kind of cyst is there. But when you open and you find the things are little different, the patient requires little more radical surgery. So now you cannot do that. Once the patient is under anesthesia, you have taken consent for removal of the skin. Now you cannot remove the uterus. Hysterectomy. This is denied. Right? This has to be kept in mind. That you will limit your surgery to what the patient has given consent. Then a person, you have told him that we want to operate upon you, you will require blood transfusion also, and you give consent for surgery. And if he says, no, I don't want, then you should not operate upon a person. Even if you have to wait till the time he becomes okay, or otherwise he becomes fit to give consent. But otherwise, there is a sect among Christians, that is Jehovah's sect. Jehovah's sect. Jehova. Jehovah. They don't accept blood transfusion even at the cost of their life. You tell them that we'll give you the blood transfusion. Jehovah's sect is there. So they never, many of them, I don't know whether it's all of them or, but there was a tradition among them that they never accept blood transfusion, so you can't give them the blood. Is that right? Understand? You cannot force anybody your opinion and operate. The results have been disastrous. I'll quote you an example of that. A person had cholelithiasis. You understand what is cholelithiasis? Because you are MBBS 1, is it? First professor. Huh? You are in which year? Second year, okay. So probably you may not be knowing about this. Anyway, you have heard about anatomy, you must have been told about gallbladder. You know where gallbladder is there? It's the right hypochondria on the undersurface of the liver, and it stores bile. Bile has got specific purpose. Okay. The patient, I am just quoting an example. Patient had cholelithiasis, that is, the gallstones were there. The surgeon convinces the person, the surgeon convinces the patient that you require surgery, that is cholecystectomy. The patient somehow refuses that I don't want to undergo surgery. He refuses cholecystectomy. What happens is patients in the ward, when a person undergoes cholecystectomy, say any surgery, but there are 2 or 3 patients who have to undergo cholecystectomy. So naturally, who has been operated, this is a tendency. The patient will go and see him in the evening or the same day after he has come back from OT and post-op ward. So you see, because those individuals who themselves are suffering from gallstone disease and have to undergo surgery will be curious and eager to see a person who has come out of OT after cholecystectomy. It's natural. Do you understand that? Okay. Then they see. So these patients, the best reputation of the doctor, the patient himself, right? So this patient in particular, he refused surgery, that I don't want to, because the surgeon, probably, I'm sorry to say that he didn't carry that kind of a, whatever you call popular sport. The patient refused surgery, but the surgeon forces him to undergo surgery. No, no, you have to undergo surgery. Then an institution, this was an institution where there is a question of, little law and law is really and attitude is very strict and disciplined. The patient undergoes surgery. He underwent surgery without, he gave a consent for surgery under duress or under stress and little bit of persuasion, force, you can say. Unfortunately, after surgery, the patient had biliary leakage. He was not informed that what are the complications of surgery. It can happen. Gallbladder surgery, if you do, there can be biliary fistula also, right? There can be bile peritonitis also, if in fact, God forbid. And there is a cholangitic shock also. This can happen. And mortality is very high. Patient can die. So nothing of that sort was told to the patient, and patient had complications. Now he tells the patient that, look, then the patient is investigated, and what they find that he had CBD stones. CBD means common bile duct. There were stones in the common bile duct, and there was error of judgment. They should have generally see when you do cholecystectomy, open cholecystectomy or this thing, you can always feel with the thumb and fingers that yes, you feel the calcium. And you can do cholecystoscopy. You can go into the inside the common bile duct and you can exclude that there are stones in the CBD or right hepatic duct, left hepatic duct, common bile duct. So that process was not undertaken. Now he tells the patient, look, listen, that you require repeat surgery, and this time there are some stones which are left inside. Now after that you will be all right. Again he is operated for CBD calculi. Stones were removed and one T-tube drainage is put inside the common bile duct. Okay. The patient becomes all right and goes to home on leave, that is called sick leave. The patient is gone home on sick leave for 8 weeks. Go to your home, and after the expiry of sick leave, after 8 weeks, you report to the nearest hospital, a tertiary care hospital, big hospital with all super specialists and things like that. He goes on sick leave, and during sick leave he has fever and chills and rigors. Fever, chills and rigors. That means he has got cholangitis now. Cholangitis, infected by it. He reports to the tertiary care hospital, they investigate him, and they do the ERCP. ERCP. What is ERCP? Endoscopic retrograde cholangiopancreatography. They find there is a stone in the common bile duct. Still one stone was left. Right? ERCP is done. The stone is removed. And they put a stent inside. Stent means near the termination of the common bile duct, at the ampulla of Beta, near that, they put a stent so there's a free biliary drainage into the duodenum. Is that right? Again he goes on sick leave. Very interesting story. And again he gets this problem. This time he goes to the capital city in a very big institute, and they undergo sphincterotomy and sphincteroplasty, and sent back to the place where he was working. I was working in that place in the periphery, and the patient was admitted to medical ward with viral hepatitis, and he became suddenly, his condition deteriorated. His abdomen was, guarding was there, and I was called to see that patient with my team. So many surgeons under me. So we diagnosed clinically that he has got bile peritonitis. So we thought of, he has undergone 7 or 8 procedures, and we planned to shift him by here. But then one of my juniors told me that no, we have to operate. I was compelled to operate on that patient. When we operated that patient, when we opened, there was a huge amounts of foul-smelling pus in the peritoneal cavity, and including the lesser sac. So deadly smell. I had not that kind of thing. It was virtually bile and the pus. So anyway, under those circumstances, what we do, a earthworm and a stone. Earthworm and a stone out of the sea with the open surgery. We retrieve that patient and we finally recover. What I mean to say is never fright a person who even once says that I don't want to undergo surgery, not ask him second time. Now he doesn't want to go into surgery, please don't operate. Okay? This is the classical example. Wherever a person has once said that I don't want to undergo surgery, his system is not permitting that, he is not prepared for surgery, don't operate. Is that right? Anyway, next comes confidentiality. Listen to girls. Just listen. What are you writing? What are you writing? Bear with me. If you don't like my talk, it's all right. Am I talking so badly? Then, okay. Confidentiality. Confidentiality means confidential. The surgeon and the patient. What is his disease? What are his symptoms? What is his diagnosis? What treatment is to be offered to him? You cannot discuss with anybody. Confidentiality is unwritten and a written understanding and a matter of faith between the two. You cannot divulge these things to anybody. Otherwise, Indian law punishes a person for the breach of confidentiality. The fines are very severe and there can be defamation and license can be cancelled. If you violate, try to defame somebody, number one, try to slander someone, talk about someone, law will not spare. If somebody asks for defamation, a good amount is waiting. Influence cancellation. And there is a law in Indian Penal Code that is, if there is some kind of a breach of trust, like you have not properly examined the patient and there is something wrong with the consent under section 500, it is 2 years. 2 years. So you cannot discuss anything with anybody, including his parents, brothers, sisters, relatives, friends, and things like that. Please do not talk about the ailment unless the patient himself tells somebody that I have got this ailment and that ailment. That is his business, right? But confidentiality is an offense if you divulge the matter to others. Is that right? So, but there is a limit to it. One has to tell your seniors a person is having COVID-19 problem. Then in some situations, like say there is an epidemic, then of course you have to tell your seniors, okay? Now breach of confidentiality does not mean that if I am a junior person and I have to seek consultation from a senior experienced person, in that event what you can do is you can discuss the matter with other consultant. That is not breach of confidentiality, that understanding with the patient. In that event, for the benefit of the patient itself, he has given you a consent for treatment, which is called, one is informed consent and that is implied consent. That it is implied, it is agreed when he has signed the paper that for the sake of my treatment, you may have consultation with your seniors, implied consent. But otherwise, you must keep the what has transacted between the surgeon and the patient, the things have to be kept in confidence, right? Then comes your research. Now when you become doctor and you go to, say, corporate hospital, there they will tell you, they'll ask you, if you are a specialist officer, they are giving you 5 lakh rupees per month or whatever money they are giving you in pay. But you have to give them business. Corporate hospitals are, frankly, to be very frank, it's a kind of a business. They have to sustain themselves, they've spent money, they've taken loans, right? And they're doing, it's service, I must say, the great service they're doing, no doubt about it. But if you are not seeing patients, the patients are not coming, he'll tell you, this has happened. Go and deliver lectures and talks in other hospitals and peripheral hospitals and fetch some patients to the hospital. You get my point? Similarly, research, your boss will tell you, and certain institutions demand that you do your research work. Then, Doctor, kindly do something new, research, find out something, write some papers, scientific papers, publish them in national and international journals. So you are under a kind of a persuasion and under a kind of a not this thing. You are being asked, forced, compelled to write research papers. And for research papers, if you are doing research, you are doing research on whom? Whom you are doing research upon? You are doing research on patients, and patient does not give consent. Then how can you do the research? So therefore, research at that time, till the time you do self-purification, you self-improvement. You have to read, you have to watch the seniors, you have to talk to the patients, and patients have to give consent for studies, those studies, okay? So in that event, if you're doing a research on a patient, you have to take permission from the Institutional Ethical Research Committee. What did I say? For each and every research paper you plan to do and you do, permission of Ethical Research Committee is required. Otherwise, they will not permit you to do the research. Okay? In a captive organization like huge forces and things like that, you have a captive crowd, so you can do any time and good, great research. I have written about 65 to 70 presentations. Papers are written, presentations, original work. And if you want to do the research seriously, I am telling you, it takes good 4 to 5 months, because we have to do the follow-up also for years together. And research means serious, honest research means extreme hard work. You have to slog it out really. You have to have number of patients with you, then you come out with some conclusion. Unless you do the research, how are we going to improve? We are not going to improve. And at times I can tell you this much, that Government of India does a lot of funding for the research. When I was on a very important assignment, that was beside my study, I was given an assignment, was a controlling 7.5 states at that time. Things are different. Anyway, what I mean to say is, people will bring out projects before the government and Director of Medical Research. The research which has already been done 10 years back in some countries. So if you are a research-oriented person and you are an important scientist, I checked people. I said this research about tranexamic assay was done long decades back, and you are putting up in research. They are trying to fool these general medical officers, GDMOs, and officials. So they have no idea about research, what research is. So what I am trying to say is, research is very important aspect, but in the meanwhile, you should see that if your research harms the patient on trial basis, the patient has to be given money. So do the full documentation, because this indemnity is very, very important aspect of doing any kind of a research. And in research, then you have to take permission from wildlife and things like that, the Forest Research Institute or whatever it is and things like that. Wild research, you are not doing hopefully experiments on animals and things like that. They also have to be taken into confidence. So research, but then it is very important, and without research we can't move ahead. Then finally I want to tell you is the clinical excellence. Clinical excellence. This is very important. Anybody who wants to open a hospital here, he has to go hundreds and hundreds of documentation, biomedical waste, clinical excellence, and environment fellows, and biomedical waste, and things like that. So in clinical excellence, everybody, all students, doctors, they must excel themselves. How you excel? Number one, you have to read. Anybody, any student, any doctor who is going to operate a patient on the next day and he has not read the previous night, he is going to commit mistakes. Even if it's a small operation like that, you are going to operate, please read. Knowledge is a very important aspect. Those persons who do not read, they are not updated, they will kill the patients. We have seen that. You have written a prescription of a medicines, in the old days Diagene. Diagene, the patient, doctor wrote Diagene tablet, 2BD or something like that. It has happened. And he goes to pharmacist, he gives tablet, digoxin, 2BD. Digoxin, it is used in cardiac failure. The patient died. Right? So, clinical excellence means you have to work very, very hard, very, very hard. You have to remain in the wards, morning, evening, and night as a training, as a what you call when you are junior residents and things like that. Okay? So therefore, and you have to read. Only then clinical excellence. It's a ruthless of discipline, surgery. Ruthless in the sense there is no scope. There's no scope for tolerating carelessness and negligence. Otherwise, we are dealing with the life patient will die. If somebody is not monitoring the patient in the ward, post of ward or ICU or things like that, so they are relaxed and think, drip might be going into the blanket and the linen. It has happened. The patients, they have died because of nobody's regulating, controlling the ventilator properly. There will be volume trauma. The lungs will just disrupted, right? Patient may go into septic ischemic shock and he may go into lactic acidosis. So you have to have a constant monitoring. And in surgical practice, if my junior is not performing, when I was head of the department in a very big university, hospital and a college, we used to train our interns also, but across the table. JRs were, because attitude is that you have to train. Unless you train the students, unless you don't let them operate, how are they going to learn? He has done the MSc, he doesn't know how to excite the lipoemulsification system. So therefore, when you are learning the skills, or when you are training your surgeons, do it across the table. Wash your hands and say, okay, doesn't matter, I'll assist the JR, so that he does not commit the patient and harm the patients, otherwise the patient will die. So therefore, you cannot leave the patient in the hands of those persons who do not carry good experience with them. That you will understand when you grow up in life. You will be able to make a good idea, but I am telling you at that stage, don't sit in the office. You have to get up from the chair in the old age, go to the operation table, wash and assist. Tell your staff that no JR would be permitted to operate unless he is being observed, monitored and assisted. So any person whose results are not good, any person who is repeatedly committing mistakes, he should be taken out of that profession and given fresh training. I think that's all my, any question you want to ask? My advice to you is, as a students, don't miss the classes, number one. Second point is read. And read through doctors. If doctor is, blessed, not condemned, is blessed to read. And reading is a very good thing. It's one of the very best friend in life is a book. Any kind of book you read, it will always pay you dividends in some way or the other. Just a Saraswati, it always comes back and it blesses you. So in medical profession, I want to tell you that keep yourself upgraded. At this age, and being a surgeon myself, I am reading book on physiology at the moment, besides my surgery and this thing. So that's all I want to talk to you, and thank you very much.